Welcome back to the deep dive. Today, our mission is, well, pretty focused. We're doing a really comprehensive review, sort of like grand rounds, on the whole world of knee imaging.
That's right.
We're not just scratching the surface here. We're going deep into this huge toolbox we use every single day. Everything from basic x-rays all the way to, nuclear medicine.
Exactly. And the goal for you, the learner, is really about synthesis.
Yeah.
We've got all this detailed source material covering, every diagnostic tool you can think of for the knee.
Mm-hmm.
And we need to boil it down into a clear, kind of actionable mental framework. As surgeons, our success really hinges on precise planning before we even step into the OR.
Right.
And this isn't just about finding the big obvious stuff like a displaced fracture. It's about truly understanding what normal looks like, the baseline normal, across every single view, every modality.
That baseline normal. Yeah, it's the roadmap, isn't it, before the operation? And if you miss a landmark on just a standard view, the whole plan could be off.
Absolutely.
I kind of think of it like trying to fix probably the most complex machine in the body, the knee. And we've got this toolbox that just keeps getting bigger, sometimes with tools that seem to contradict each other.
That's a good way to put it.
We need to know which wrench, which imaging modality is the best fit for which specific bolt, which pathology.
And maybe even more critically, knowing when the cheap fast wrench is actually enough versus when you absolutely have to pull out the, $1,000 diagnostic laser system.
Yeah.
That understanding, well, that's what separates the residents from the attending surgeons, frankly. So let's start with maybe the most fundamental wrench we have, radiography. The absolute workhorse.
Okay, yeah, let's unpack that. Radiographs, they're always called the workhorse for that first look, right? Trauma, arthritis, deformity, checking on joint replacements.
Pretty much anything knee-related, yeah.
Clinically, what's the core thing that makes this simple 2D picture so powerful?
Well, it's fast. It's accessible pretty much everywhere. And it gives us the skeleton almost instantly. And let's face it, 90% of the acute problems we see involve the bone.
Mm-hmm.
But to really appreciate why it works, you have to grasp the basic physics, the whole shadow puppet show idea you mentioned.
I always found the physics kind of neat because it seems simple, but it's effective. We're basically taking electricity, turning it into a beam of high-energy photons.
Right.
And when that beam hits the knee, it's all about how much gets stopped by the different tissues.
Density, attenuation, right.
Exactly. Attenuation is the key word. Dense stuff, mostly bone, attenuates those photons a lot. It absorbs or deflects most of that high-energy light.
Okay.
So fewer photons actually make it through to the detector behind the knee. That area on the detector stays unexposed, so it looks white, or radiopaque.
And the less dense things.
Things like air or fat or even fluid. They don't stop the photons nearly as much. So more photons hit the detector, it gets exposed more, and those areas look dark, radiolucent.
So we're essentially looking at a shadow map, and the differences in shading are all down to how much the different tissues absorb the x-rays.
So it really is just a sophisticated shadow, high energy light outlining the anatomy, fast, cheap, gives us the bones, but only the shadow, really.
Precisely. And, in the last, 30 years, how we capture that shadow has changed completely. We're mostly past traditional film now.
Yeah, the first step was CR, right? Computed radiography, using an image plate that you had to scan afterwards to get the digital image.
Right. A bit clunky compared to now.
And now the standard is DR, digital radiography. Uses a flat panel detector right there.
Yep. And the advantages are huge. Immediate image acquisition, much better detail, better dynamic range than CR. You can see more shades of gray.
And from just a practical standpoint, managing all these images, PASS-CS has been revolutionary. Picture archiving and communication system.
Oh, absolutely. Forget just storing them electronically. The real clinical value is being able to manipulate the image right there on the screen.
Right. Think back 20 years. If the film was too light or too dark,
You had to reshoot. Waste of time, more radiation.
Exactly. Now we can zoom in, measure angles, and crucially, we can adjust the window and level.
Within limits, of course. But you can tweak the brightness and contrast to really optimize it for looking at fine bone detail, or switch it to see soft tissue outlines better. It really did kill the old file room hunt, thank goodness. Remember those days? Hunting through shelves.
Oh, yeah. Good riddance. Hashtag 1.2 essential radiographic views and positioning.
Okay, so let's talk views, the ones we rely on day in, day out. When we order a standard knee series, we expect that triad, AP, lateral, and an axial view, like a sunrise or a merchant.
Yeah, but the key point, the one we always hammer home in clinic, is about that AP view. It really should not be supine if you can help it. That gets missed way too often.
That is probably the single most important detail when you're looking for wear and tear, especially osteoarthritis. A standing weight-bearing AP radiograph. That's the absolute minimum standard whenever the patient can tolerate it.
Why is it so critical?
Because it shows what the knee is actually doing under load. When the patient is lying down, supine, the joint space can look deceptively wide. It can completely mask significant cartilage loss, even end-stage bone-on-bone arthritis.
And that makes a huge difference in how we manage the patient, right?
Right.
A borderline supine film might just get physical therapy.
Exactly.
But a standing film showing bone on bone, that patient's probably getting scheduled for a TKA consultation right then and there. We need that standing view to really see the joint space narrowing accurately and also to get a sense of the overall alignment, any varus or valgus stress.
Right. If you look at a typical example like in figure 5.2a, you assess that overall femoral tibial alignment. And remember, normally the lateral compartment is just a touch wider than the medial. Missing a big mechanical shift, say 10 degrees of varus, just because you get a supine film, that's a major clinical miss.
Okay, so standing AP is king for arthritis and alignment. What about the lateral view, usually done with the knee bent about 30 degrees? This one seems packed with landmarks.
It really is. On the soft tissue side, you're looking right at the extensor mechanism. You check the quad tendon, inserting onto the patella, the patellar tendon itself. Especially if there's been acute trauma, you're looking for ruptures.
And the bony clues?
Lots of them.
Yeah.
You can usually tell the condyles apart. The medial femoral condyle is a bit bigger. And critically, you identified the Blumensatt line.
Ah, yes, the roof of the intercondylar notch.
Exactly. In a normal knee, the lower pole of the patella should basically fall between the Blumensatt line and the old growth plate scar, the closed physis. You can see that nicely in figure 5.2b. If the patella is sitting way above that line.
Patella alta.
High-riding patella.
Right. And that immediately makes you think about potential instability.
And for subtle fractures, like tibial plateau fractures, knowing the back contours of the tibia is key too, isn't it?
Absolutely. The medial tibial spine is higher.
Right.
And importantly, if you look posteriorly on the lateral view, the medial plateau has a distinct squared-off appearance. It just drops off quite abruptly.
Whereas the lateral plateau slopes down more gradually. It has a smoother, more rounded posterior contour.
Why does that matter so much?
Well, imagine you're scrubbing in on a complex tibial plateau fracture case. You're using that lateral view intraoperatively with the C-arm. Knowing those posterior shapes helps you figure out exactly where the fracture lines are running, whether it involves the more stable medial side or the trickier lateral side. These little anatomical details, they make all the difference in understanding the pattern.
It's amazing how much info is packed into that one view.
It really is.
And speaking of the patella's position, that brings us to the sometimes dreaded Insall T ratio.
Ah, yes. Quantifying patellar height. Every resident's favorite calculation on a Monday morning.
Huh. So remind us, how is it calculated?
Okay, it's pretty straightforward. You measure the greatest diagonal length of the patella itself. Let's call that P. Then you measure the length of the patellar tendon from the lower pole of the patella down to the tibial tubercle. Call that T. The ratio is just P divided by T.
Patella length over tendon length. P over T.
Exactly. And the normal range is actually pretty tight, about 0.8 to 1.2. The average is around 1.17, maybe 1.2.
But the abnormal values.
Technically, patella alta, the high-riding one, is anything greater than 1.3. That's often linked with a higher risk of the patella popping out, recurrent instability.
Okay.
And patella baja, low-riding, is less than 0.8. You often see that after trauma or previous surgery, maybe due to scarring or shortening of the tendon.
And why is quantifying this so important? Why not just eyeball it?
Because it feeds directly into surgical planning, especially for instability or even some TKAs. If you're planning, say, an MPFL reconstruction for recurrent dislocations.
Medial patellofemoral ligament reconstruction.
Right. If the patient has significant patella alta, just doing the soft tissue MPFL might not be enough. You often need to address the alta concurrently with a tibial tubercle osteotomy, a PTO.
Moving the insertion point of the tendon down.
Exactly, to normalize that Insall-Salvati ratio and improve how the patella tracks in the groove. If you ignore severe patella alta and just do the MPFL, you're kind of setting that soft tissue repair up for failure. The X-ray gives you that crucial number to guide the decision.
Okay, so if the standard views are the introduction, these supplemental views are more like the deep dive for specific problems, right? Let's talk trauma first. High energy injury, You suspect something's broken inside the joint, maybe a tibial plateau fracture, but the patient can't stand or bend the knee for standard views. What's the go-to film then?
That's when you absolutely need the cross-table lateral view. Patient stays supine, beam comes in horizontally from the side.
And what are we looking for?
The definitive sign of an intra-articular fracture, especially one that's not obvious on the AP. We're looking for lipohemarthrosis.
The fat fluid level. Love this one. It's basic physics again, isn't it?
It is. If the fracture is broken into the joint, you get bleeding, hemarthrosis. But you also get marrow fat leaking out from the fracture site into the joint fluid.
And fat is less dense than blood.
So it floats. On that horizontal beam lateral view, you see a distinct layer. Darker fat signal floating on top of the denser blood fluid level. Figure 5.3a through C shows it perfectly.
Seeing that layer is basically a guarantee the fracture goes into the joint.
It's a huge red flag. It absolutely confirms intra-articular extension. That finding immediately tells you this needs more investigation, usually a CT or maybe an MRI because you have to deal with the joint surface itself. Needs surgical planning.
Okay, moving away from trauma, let's look at the kneecap joint, the patellofemoral joint. The axial view of choice nowadays is the merchant view. Why do we like the merchant more than the older skyline or sunrise views?
Ah, the skyline view. Yeah, that's the one where you practically have to fold the patient's knee right up to their chest.
Super uncomfortable.
Exactly. It's often painful, poorly tolerated, and because the knee is flexed so much, it can actually distort the true relationship between the patella and the trochlear groove. It might make things look better or worse than they really are.
So the merchant is better because
It's done at a more moderate flexion angle, typically 45 degrees, as you see in figure 5.4. It gives a really good standardized assessment of patellofemoral alignment and lets you see the articular surfaces quite well. It's just more reproducible and better tolerated.
got it. And for looking way in the back into the intercondylar notch.
That's where the tunnel view comes in.
Okay.
Usually done with the knee flexed more, maybe 60 degrees or so. The beam is angled to shoot right through that tunnel between the condyles.
And what are we looking for specifically there?
It's the best view for evaluating the posterior aspect of the notch itself, and really importantly, for looking for osteochondritis dissecans, or OCD lesions.
Those little pieces of bone and cartilage that can loosen up?
Exactly. They classically occur on the posterior aspect of the medial femoral condyle, right in the area the tunnel view highlights. You're looking for that little crescent of lucency, maybe a loose fragment like in figure 5.5b. It's perfect for seeing if that fragment looks unstable.
Okay, and one more specialized view, really key for diagnosing arthritis early, the Rosenberg view.
Ah, yes, the Rosenberg. This is a fantastic view, but maybe underutilized sometimes. It's a modified weight-bearing view, but it's PA, posterior-anterior.
So the beam goes from back to front.
Right. And crucially, the patient is standing with their knees flexed, usually about 45 degrees. Why do we do this instead of just the standard standing AP?
Because standard AP looks at the joint space more anteriorly, right, but the wear often starts posteriorly.
Precisely. The standard AP averages the joint space across the whole condyle. But when you flex the knee under load, like in the Rosenberg view, you're capturing the contact point at the posterior aspect of the joint. That's often where the cartilage loss begins, and it can be drastically underestimated on a regular standing AP.
So the Rosenberg gives a truer picture of the functional joint space narrowing.
It really does. It significantly boosts the accuracy, sensitivity, and specificity for picking up subtle joint space loss. If you compare them like in figure 5.6, the standard AP might look only moderately narrowed. But the Rosenberg view, showing that contact point inflection, might reveal complete burn on bone. It gives you a much better idea of the true stage of the arthritis. Hashtag tags 1.4 alignment and variance.
Okay, since we're thinking like surgeons here, especially with total knee arthroplasty TKA in mind, we absolutely have to nail the difference between the anatomic axis and the mechanical axis.
Non-negotiable. This is fundamental. The anatomic axis is just the angle formed by the shafts of the femur and tibia themselves. Normally, there's about 6 or 7 degrees of valgus there.
Knee slightly knock-kneed.
Right. But when you're planning a TKA or just trying to understand how the load is actually going through the leg, the anatomic axis isn't really sufficient.
We need the mechanical axis.
Exactly. The true weight-bearing line, defined as a straight line drawn from the center of the femoral head all the way down to the center of the ankle joint, specifically the tibial plafond.
And how do we visualize that?
You need a special X-ray, a long-standing frontal view, sometimes called a hip-to-ankle scanogram. It captures the entire lower extremity on one film, as you see in figure 5.32.
Okay.
Then you draw that line from hip center to ankle center, and you see where it crosses the knee joint. Just pass through the center, medial to the center, lateral.
If it passes medial, that's varus, bow-legged. Lateral is valgus, knock-kneed.
Precisely. And this isn't just descriptive, it's quantitative. We measure the deviation from the center. Getting that mechanical alignment restored to neutral, or very close to it, is a primary goal of TKA. Even a small residual mechanical malalignment, say 3 degrees off after surgery, can significantly affect how the implant wears over time and its overall longevity.
So the long leg film is crucial for pre-op planning and assessing deformity. Let's circle back to the patellofemoral joint again, using those merchant view metrics to quantify things. This is how we put numbers on instability, right?
Yes, absolutely. Beyond just saying it looks subluxed, the two key ones are the sulcus angle and the congruence angle. You can see how they're measured in figure 5.11.
Okay, the sulcus angle measures the depth of the groove, the trochlea that the patella runs in.
Right. You draw lines along the highest points of the medial and lateral facets of the trochlea. The angle formed where they meet inferiorly is the sulcus angle. Normal is around 138 degrees, plus or minus about 6 degrees.
And if it's much larger than that, say over 144 degrees.
That indicates a shallow trochlear dysplasia. The groove isn't deep enough to properly contain the patella, which is a major risk factor for recurrent patellar dislocations.
Okay, shallow groove equals higher risk, and the congruence angle.
That one directly measures how centered the patella is within that groove. It's a bit more complex to draw, but essentially you find the lowest point of the sulcus, bisect the sulcus angle to get a reference line, and then measure the angle between that reference line and a line drawn to the lowest point, or apex, of the patella. If the patellar apex is lateral to that reference line, the angle gets a positive value. Normal is pretty close to 0, maybe around -6 degrees actually, slightly medial, with a range of plus or minus 11 degrees or so.
So a positive value means lateral subluxation.
Exactly. If you start seeing congruence angles consistently over plus 15 or plus 20 degrees, that patella is significantly shifted laterally.
And why are these numbers so important surgically?
Well, because they guide treatment. If someone has recurrent instability but relatively normal angles, maybe just an MPFL reconstruction is enough. But if they have severe trochlear dysplasia, a huge sulcus angle, or significant lateral subluxation, a large positive congruence angle, a soft tissue procedure alone might fail. You might need to consider a bony procedure, like deepening the groove with a trochleoplasty, or shifting the tibial tubercle medially with an osteotomy to correct the alignment fundamentally. The numbers help justify the more complex surgery.
Got it. Before we leave x-rays, we have to mention those little things that always trip up the junior residents in the ER at 3 a.m.
Yeah.
The sesamoids.
Huh? Yes, the fibella and the cyamella. The fibella is the common one. It's a little sesamoid bone embedded in the lateral head of the gastrocnemius muscle. You see it on the AP view, kind of floating behind the lateral femoral condyle, like in figure 5.8.
And the cyamella.
Much less common. It sits within the popliteus tendon, more posterior. They're just normal variants, little extra bones, but you have to recognize them so you don't mistake them for a loose body or some kind of weird fracture fragment.
And the other classic trap, the bipartite patella. Looks like a broken kneecap, but isn't always.
Right. This occurs in about 1% of people. It's where the patella didn't fully fuse during development, leaving a separate fragment, usually in the superlateral corner. Figure 5.9 shows a typical example. It's often bilateral, which is a good clue.
So how do you tell it apart from an acute fracture?
The key is the edges and the clinical picture. A true acute fracture line is usually sharp, irregular, maybe jagged. The fragments might be displaced. And crucially, there's usually associated soft tissue swelling or a joint effusion. A bipartite patella, because it's a developmental non-union at a syncondrosis, typically has smooth, well-corticated, rounded edges where the fragment meets the main patella. The two pieces often fit together perfectly.
The jigsaw puzzle analogy.
Exactly. If the pieces fit together like a perfect jigsaw puzzle and the edges look smooth and sclerotic, it's almost certainly a long-standing bipartite patella.
But what if the patient does have acute pain right there?
That's the tricky part. They can injure the fibrous connection, the syncondrosis, or just get a bone bruise near it. If there's acute trauma, localized tenderness, and maybe some swelling, even if it looks like a bipartite, you might need an MRI to see if there's edema or fluid signal at that interface, suggesting an acute injury versus just the chronic variant. I remember a case early on, 16-year-old kid, football player, acute knee pain after a tackle. X-ray showed that classic superolateral fragment. I was totally convinced it was an avulsion fracture off the patella.
Makes sense.
Turns out, we got comparison views. He had perfectly symmetrical bilateral bipartite patellae, completely asymptomatic on the other side. The MRI just showed some bone bruising nearby, but the synchondrosis itself was stable. No acute signal change across it.
Wow.
Yeah. The jigsaw puzzle clue and checking the other side saved that kid from potentially unnecessary surgery. Moral of the story: know your normal variants or they will fool you eventually.
Okay, so x-rays give us the shadow, but sometimes we need more. We hit the limits of that 2D view, especially when mapping out complex fractures or bone shapes. That brings us to CT, computed tomography.
Right. And the analogy here works well. If X-ray is just looking at the car from the front,
CT is like walking all the way around it, seeing it from every angle, getting the 3D picture.
exactly, it's really the go-to problem solver for complex bone issues. The computed part is key. It takes thousands of individual X-ray projections from different angles and uses a computer to reconstruct a detailed cross-sectional image. A density map, essentially.
And it quantifies density using Hounsfield units, HU.
Water is zero, right? Water is the zero reference point. That's the standard. Air is way down at negative 1,000 HU, super dark. Dense cortical bone can be plus 400 HU or much higher, very bright.
Why is having water as zero so useful?
It provides a universal standard for comparison. A simple cyst filled with water will measure around 0 HU anywhere in the world. It allows for quantitative assessment. We can measure the density of bone to assess osteoporosis or look for fat density within a bone lesion. Fat measures around negative 100 HU, which might suggest a benign lipoma, for example.
And the big technical leap with modern CT is helical scanning and getting isotropic voxels.
Yes, a voxel is just a 3D pixel. Isotropic means it's a perfect cube, the same resolution in all three dimensions: length, width, and height.
And why is that so important?
Because it means we can acquire the data in one primary plane, usually axial, slices like a loaf of bread, and then the computer can reformat that data into perfect sagittal, side view, coronal, front view, or any oblique plane we need without losing any detail or resolution. Figure 5.15 illustrates this beautifully. This multiplanar reformation MPR capability is absolutely fundamental for understanding complex anatomy and pathology. Hashtag 2.2 applications and technical challenges.
So clinically, where does CT really shine for the knee? Complex trauma seems like the big one. Tibial plateau fractures, for instance?
Indispensable. For tibial plateau fractures, an X-ray might show you there is a fracture, maybe some depression or displacement, but the CT gives you the detailed roadmap you need for surgery.
We use classifications like Schatzker or maybe the 3-column concept based on CT.
Right. The CT tells you exactly how depressed the articular surface is, down to the millimeter. Is the split mainly anterior, or does it extend way posteriorly, meaning you might need a separate posterior surgical approach? Are the main fragments just split, or are they significantly shifted or rotated? That isotropic data lets us make precise measurements.
Which dictates the whole surgical plan, right? Hardware choice approach.
Absolutely. Yeah. Are we just putting in a simple buttress plate, or is it so smashed up we need complex plating or even an external fixator initially? The CT answers those questions.
It's also great for finding loose bodies floating around in the joint and increasingly used for pre-op planning for joint replacements too, sometimes even generating patient-specific cutting guides.
Definitely. Now, when you're looking at these complex CT datasets, especially with all the reformats, optimizing the image display is critical. We have to talk about windowing.
Right. Just opening the scan in PyCS might not show you what you need to see. You have to adjust the settings.
Exactly. You manipulate two things, the level and the window. The level is basically the center density you're focusing on. The window is the range of densities displayed around that center level.
So if you want to see bone detail clearly,
You use bone windows. You set the level high, maybe around 500 HU, because that's in the range of bone density, and you use a wide window, maybe 2000 HU or more. This displays a huge range of densities, from dense cortical bone down to marrow, giving you great contrast within the bone itself.
but if you're looking for something soft tissue related, like a cyst or fluid collection,
Then you have to switch dramatically. You use soft tissue windows, set the level much lower, maybe 40 HU, close to water muscle density, and use a much narrower window, perhaps 400 HU. This compresses the grayscale, making subtle differences in soft tissue densities much more apparent. Figure 5.17 shows this perfectly the same slice looks completely different depending on the window settings.
it's a fundamental skill. If you don't window properly, you will miss things.
No question.
Okay, the big elephant in the room with CT in orthopedics, especially after surgery, metal. Arthroplasty components, plates, screws. They cause huge artifacts.
Ugh, yes. The bane of our existence on CT scans. Metal is so incredibly dense compared to tissue that it wreaks havoc with the X-ray beams passing through it. You get severe streaking artifacts, dark bands, and bright spots. It can totally obscure the adjacent bone and soft tissues.
Making it impossible to see if there's loosening around an implant or bone loss osteolysis.
Exactly. Which is why we now rely heavily on metal artifact reduction techniques, often called MARS protocols, though different vendors have different names.
How do those work, basically?
The core idea is to use a harder X-ray beam one with more penetrating power. We increase the tube voltage, kVp, and the tube current time product,
Yeah.
MASs, more photons, more powerful photons to try and get through the metal without being completely absorbed or scattered.
Okay, blast through the metal.
Sort of. And we also usually change the reconstruction algorithm. You might think a bone algorithm would be best, but paradoxically, around dense metal, a standard or soft tissue algorithm often produces less streak artifact.
Interesting.
And the results can be dramatic. Look at figure 5.16. That's an image around a knee replacement that historically would have been almost unreadable near the implant. But with MARS, you can actually start to see the bone interface, maybe pick up subtle areas of osteolysis, those dark areas suggesting bone resorption, which could indicate implant failure or polyethylene wear debris. Without MARS, that whole zone would just be a mess of streaks.
So Mars is crucial for post-op CT, but we should also mention other artifacts briefly, like partial volume.
Yeah, partial volume averaging used to be a bigger issue with older scanners and thicker slices. If a single voxel contained two very different densities, like bone and fluid, the scanner would just average them, potentially obscuring small details. Modern scanners with very thin slices, often sub-millimeter, have minimized this significantly.
And beam hardening.
That's related to the metal artifact. As the X-ray beam passes through dense material like metal or even concentrated contrast dye, the lower energy photons get preferentially absorbed. The beam becomes harder, higher average energy. This change in beam quality can cause streaks or dark bands radiating away from the dense object. MARS techniques help mitigate this too. Hashtag tag 2.3 CT safety profile.
Okay, we've talked about how useful CT is, especially with Mars, but we have to address the safety aspect. Unlike MRI, CT uses ionizing radiation, and the dose is significantly higher than a plain X-ray, right?
Oh, absolutely. It's not even
go ahead.
close. It's an order of magnitude, or sometimes several orders of magnitude, higher.
We should try and quantify that for people. A simple knee X-ray series might be what, maybe 1 millirem effective dose? Very low.
Tiny, less than a day's background radiation for most people.
But a CT scan, even just of the knee, it's considerably more.
Wow.
And if you get a CT of the abdomen and pelvis, which is common in trauma,
That could easily be 500, 600, even 1,000 millirem or more, depending on the protocol. Now, a dedicated knee CT is usually less than that, but it's still way, way more radiation than an X-ray.
and the concern is the cumulative effect over a lifetime, especially in younger patients or people needing repeat scans.
Exactly. We always have to weigh the benefit of the information we'll get from the CT against the radiation exposure risk. It's a constant calculation.
Is this leading to changes in practice? Are we perhaps leaning more towards MRI, even for some fractures, especially in kids or young adults, to avoid that CT dose?
I think we are. We're appropriate. If you have, say, a younger patient with a suspected simple tibial plateau fracture, maybe a Schutzker high or 2, where the main question is about the articular surface depression and maybe associated soft tissue injuries.
Ligaments, meniscus.
Right. If the patient is stable and can tolerate an MRI, many centers will now opt for the MRI instead of CT. It gives you excellent articular surface detail, plus it shows you the ligaments and menisci, all without any ionizing radiation.
So MRI can sometimes do double duty, assessing bone and soft tissue without the radiation cost?
In selected cases, yes. We tend to reserve CT more for the really complex comminuted fractures where visualizing every tiny fragment is paramount, or for evaluating things like fracture healing, seeing bridging bone, or maybe in the setting of revision arthroplasty where the metal artifact might still be too severe even for MRI MARS protocols. It forces us to be judicious. Order the right test for the right reason at the right time, considering the radiation burden. Okay, so if X-ray gave us the chassis and CT gave us the precise frame measurements, then MRI, well, MRI is everything else. It's the internal moving parts, the hydraulics, the wiring, the upholstery, everything inside.
Yeah, it's definitely the gold standard for looking at the soft tissues, ligaments, tendons, meniscus, cartilage. And also great for subtle bone problems, tumors, infection.
Its versatility is just incredible. And that's because the underlying physics is completely different from X-ray or CT. It's not measuring density by passing radiation through the body.
Right. It's using magnetism and radio waves to look at how hydrogen atoms behave. Specifically, the protons and hydrogen nuclei, which are everywhere in the body, especially in water and fat.
Exactly. We put the patient inside a massive magnet, typically 1.5 or 3 Tesla, which is, 30,000 to 60,000 times stronger than the Earth's magnetic field.
Whoa.
This forces a tiny fraction of those hydrogen protons to align with the magnetic field. Then we hit them with a specific radio frequency pulse that knocks them out of alignment.
Okay.
And the MRI scanner essentially listens for the radio signal that those protons emit as they relax back into alignment with the main magnetic field after the pulse is turned off.
And different tissues relax at different rates.
Precisely. That's the key. How quickly those protons relax depends on the molecular environment they're in. They're tightly bound in collagen or freely moving in water. These different relaxation times are called T1 and T2.
And the specific timing of the radio frequency pulses and when we listen for the signal that determines the type of image we get, the sequence.
Yep. We control the time to echo, TE, how long we wait after the pulse before listening, and the time to repetition, PR, how long we wait before sending the next pulse. By varying TE and TR, we create different image weightings, T1 weighted, T2 weighted, proton density, PD weighted, and others. Each highlights different tissue characteristics.
Okay, the practical rule of thumb for us clinicians, T1 is good for anatomy, T2 is good for pathology. Why is that?
Generally speaking, yes. T1 weighted images provide excellent anatomical detail because fat, which outlines many structures, appears bright, high signal.
Yeah.
Fluid, however, is dark, low signal on T1.
Okay.
T2 weighted images are often called fluid-sensitive sequences. On T2, fluid including edema, inflammation, joint effusions, cysts appears bright, hyperintense, since most pathology involves increased water content.
Injury, infection, swelling.
Right. Those areas light up brightly on T2 images, making them stand out against the generally darker background tissues. So T2 is where we hunt for the hot spots, indicating something's wrong.
But wait, there's a catch, isn't there? Bone marrow, normal fatty marrow is bright on T1.
Exactly.
But if you have pathology causing edema within the marrow, like a stress fracture or infection, the edema is bright on T2, but the surrounding normal fatty marrow might also look somewhat bright on certain sequences. They can sometimes blend together or mask each other.
That's where fat suppression techniques become absolutely crucial. We need a way to turn off the bright signal from normal fat so that the bright signal from fluid edema really pops out.
How do we do that?
There are a couple of main ways. Chemical fat saturation uses specific radio frequency pulses tuned to the resonant frequency of fat molecules, effectively canceling out their signal. Another very common method is SFIR short tau inversion recovery. STAR uses a specific inversion pulse timing that nulls the signal from fat before the main imaging sequence runs.
And the result?
The result is that normal fatty marrow appears dark, while fluid and edema remain bright. It dramatically increases the conspicuity of bone marrow lesions. Look at figure 5.20, the difference is striking. A subtle bone bruise or stress fracture that might be hard to spot on a regular T2 can just scream at you on the fat-suppressed sequence. It's essential for finding subtle marrow pathology. Hashtag 3.2 ligament anatomy. The cruciates and collaterals.
Okay, let's use that power to trace the ligaments. This is really where high-resolution MRI shines, right? Seeing the actual fibers, checking for tears. Let's start inside with the cruciates, the ACL.
Right, the anterior cruciate ligament. Primary stabilizer against the tibia, sliding forward on the femur. Anterior tibial translation.
Where does it run?
It runs from the medial aspect of the lateral femoral condyle down to the anterior intercondylar area of the tibia. On the sagittal view, a key landmark is that it runs roughly parallel to the Blumenstadt line, that roof of the notch we saw in X-ray.
And what should it look like normally?
It should be a well-defined, taut band of low signal intensity, dark fibers, continuous from femur to tibia.
But it's not always perfectly black, is it? Sometimes it looks a bit grayish inside.
That's a really important point. The ACL isn't just one solid cord. It's actually composed of two main bundles, the anteromedial and the posterolateral bundles. And normally, there's a bit of fat, synovium, and tiny blood vessels running between and around these bundles. This gives it some normal intermediate signal intensity internally. Figure 5.22 shows this well. You shouldn't mistake that normal internal signal for a tear.
So how do you diagnose a tear then?
You're looking for disruption of the fibers. That could be complete discontinuity or abnormal high signal, right on T2PD, within the substance of the ligament fibers themselves, obscuring that normal low signal structure. Often the ligament looks lax or wavy instead of taut. And you might see secondary signs like bone bruises in specific locations, lateral femoral condyle, posterior tibial plateau, from the impact during the injury.
The classic non-contact pivot injury.
That's the most common mechanism, yes. Foot planted, body twists, pop.
Okay, what about the PCL?
The posterior cruciate ligament. It's bigger, stronger than the ACL. Primary restraint against the tibia sliding backwards on the femur. Posterior translation.
Where does it attach?
It runs from the lateral aspect of the medial femoral condyle back to the posterior intercondylar area of the tibia.
And its appearance.
On sagittal views, it's typically seen as a single, uniformly low-signal dark band that has a gentle convex curve downwards. Figure 5.23 shows that classic appearance. It should look robust and continuous.
Injury mechanism different from ACL.
Often, yes. PCL tears are frequently caused by a direct blow to the front of the tibia when the knee is bent, the classic dashboard injury in a car accident, or sometimes from a severe hyperextension injury or a fall onto a flexed knee.
And PCL tears can be bad news, right? Especially high-grade ones.
Very bad news. A complete PCL tear is often associated with other significant injuries, particularly to the posterolateral corner of the knee. If you miss that associated PLC injury, even a perfectly reconstructed PCL might not restore stability. It requires a high index of suspicion.
Okay, let's move to the sides, the collaterals. Medial side first. The MCL, medial collateral ligament complex.
Right. The MCL's main job is to resist valgus stress forces trying to push the knee inwards, opening up the medial side. It's also an important secondary stabilizer against lateral patellar subluxation.
And it's not just one structure, is it? There are layers.
Correct. It's a complex. Broadly, we think of 3 layers medially. Layer 1 is the deep fascia. Layer 2 contains the main strong band, the superficial MCL. And layer 3 is the deep MCL, which includes thickenings of the joint capsule itself, like the meniscofemoral and meniscotibial ligaments.
And how do we assess it on MRI?
Coronal views are key. You look for the superficial MCL, which is usually a clearly defined low-signal band running from the medial femoral epicondyle down to the tibia, quite a distance below the joint line. The deep layers are harder to see distinctly.
What does a tear look like?
Depends on the grade. A grade 1 sprain is just high-signal edema around the ligament, but the fibers are intact. Grade 2 means partial tearing, so you see high signal within the ligament substance and some fiber disruption, but still continuity. Grade 3 is a complete tear, discontinuity of the fibers, often with fluid filling the gap.
And there's a bursa in there too.
Yes, the medial collateral ligament bursa sits between the superficial and deep layers. Sometimes fluid in that bursa can mimic or indicate a tear, so you need to look carefully at the ligament fibers themselves. Figure 5.24 helps visualize this complex. Most isolated MCL tears, even grade 3, heal well without surgery.
Okay, now the lateral side. The LCL complex, or the posterolateral corner PLC, this seems even more complicated.
It is. Anatomically, it's probably the most complex area of the knee.
Yep.
Its job is to resist varus stress forces trying to push the knee outwards and also to resist external rotation of the tibia.
It's often injured along with other ligaments, right?
Very often, especially with ACL or PCL tears. Isolated PLC injuries are rare. And unfortunately, PLC injuries are often missed initially, which can lead to chronic instability and failure of other ligament reconstructions down the line.
So what are the key structures we look for on MRI?
Again, thinking in layers helps. Layer 1 is superficial, IT band biceps femoris. Layer 2 is deeper. Layer 3 is the deepest, containing the joint capsule and the critical static stabilizers. The LCL proper, also called the fibular collateral ligament, the popliteus tendon and its attachments, popliteofibular ligament, and the arcuate ligament complex.
The LCL proper is the main work.
It's a key one, yes. It's a cord-like structure running from the lateral femoral epicondyle down to the fibular head. Tears of the LCL proper are strongly associated with that problematic posterolateral instability.
How do we spot PLC injuries?
Again, coronal views are often best for the LCL itself. You look for that cord-like LCL. Is it continuous? Is there high signal within it or around it? Is the fibular head avulsed? You also need to carefully trace the popliteus tendon coming up from posteriorly and diving deep. Sagittal and axial views help with the popliteus and other components. Figure 5.25 gives a sense of this complexity. Recognizing PLC injuries is critical because they almost always require surgical repair or reconstruction, often combined with ACL or PCL surgery. Hashtag tag 3.3 meniscal anatomy invariance.
All right, let's talk about the menisci. The C-shaped shock absorbers between the femur and tibia, fibrocartilage.
Crucial structures. They distribute load, improve joint congruity, provide stability. They even play a role as secondary stabilizers, especially in an ACL-deficient knee.
And on MRI, they should normally look like.
On sagittal views, they appear as dark, low-signal triangles, the classic bow tie shape when you see the body segment on two adjacent slices. On coronal views, they're also dark wedges.
You mentioned the red zone concept earlier. That's about blood supply, right?
Exactly. The outer periphery of the meniscus, maybe the outer 10–30%, has a decent blood supply coming from the joint capsule. This is the red zone. Tears in this peripheral zone have a much better potential to heal, either on their own or with surgical repair, stitching them back together.
And the inner part?
The inner majority of the meniscus is essentially avascular, the white zone. It gets nutrition just from diffusion from the synovial fluid. Tears deep within the white zone have very poor healing potential, which is why they are often treated with debridement, just trimming out the torn, unstable fragment.
That blood supply really dictates the surgical strategy. Now, medial versus lateral meniscus, they're different, aren't they?
They are. The medial meniscus is large and C-shaped. Importantly, its posterior horn is significantly larger, about twice the size of its anterior horn. Figure 5.26 shows this asymmetry.
And it's less mobile.
Much less mobile. It's firmly attached to the joint capsule all the way around and also to the deep MCL. This relative lack of mobility makes it more vulnerable to tearing, especially with twisting injuries. Medial meniscus tears are much more common than lateral.
Okay, and the lateral meniscus?
The lateral meniscus is smaller, more semicircular or O-shaped. Its anterior and posterior horns are roughly symmetrical in size. Figure 5.27 shows this.
And it's more mobile.
Yes, much more mobile. Its attachment to the capsule is interrupted posteriorly by the popliteal hiatus, the gap where the popliteus tendon passes through to enter the joint. Figure 5.28. This release allows the lateral meniscus to move more freely, making it less susceptible to getting trapped and torn during knee motion.
Interesting. So how does a tear actually appear on MRI? What's the rule?
The classic definition of a meniscal tear on MRI is an abnormal signal intensity, usually linear, sometimes complex, that unequivocally reaches an articular surface. That surface can be the top femoral surface, the bottom tibial surface, or the free inner edge.
So if the bright signal is just contained within the substance of the meniscus and doesn't break through to the surface?
That's usually considered intersubstance degeneration, often called grade 1 or grade 2 signal. It represents mucoid degeneration or microscopic tearing within the meniscus, but it's generally not considered a surgical lesion unless it's causing specific symptoms or is associated with a cyst. The key is, does the signal touch the surface?
Okay, but you hinted earlier, is that rule absolute? Do we ever operate on something that doesn't clearly hit the surface?
Yes. The clinical nuance. The most common exception is the complex horizontal cleavage tear. These are often chronic degenerative tears where the meniscus splits horizontally, like layers of an onion.
Okay.
Sometimes, on the MRI, the main cleavage plane might not seem to extend all the way to the surface on every single image. However, the patient might have very clear mechanical symptoms, locking, catching, painful clicking, because that internal flap is unstable and getting caught in the joint.
So the symptoms guide you?
In that specific situation, yes. If a patient has convincing mechanical symptoms that correlate perfectly with the location of a significant horizontal cleavage tear on MRI, even if the radiologist technically calls it grade 2 signal, not definitively surface reaching, most surgeons would still offer arthroscopy. The clinical picture often overrides the strict MRI definition for symptomatic cleavage tears.
That's a really important practical point. We also need to recognize specific tear patterns, right? Like the bucket handle tear.
Yes, the bucket handle tear is a classic. It's a large longitudinal tear where the inner fragment flips over into the intercondylar notch, like the handle of a bucket.
And that causes locking.
Often causes true locking, where the patient can't fully extend the knee. On MRI, you look for the displaced fragment in the notch. Sometimes it lies anterior to the PCL, creating the double PCL sign on sagittal images. You also see the remnant of the meniscus looks smaller than usual. Bucket handle tears usually require urgent arthroscopy to reduce the fragment and ideally repair it.
Okay, let's talk MRI traps again, the pseudo-tears. We mentioned the discoid meniscus before with x-rays, but MRI really shows it.
Yes, MRI confirms it. Remember, it's that developmental variant where the meniscus is disc-shaped instead of C-shaped. Much more common laterally, can be asymptomatic or can cause clicking, pain, or tearing.
And the MRI diagnostic clue?
It's based on the sagittal images. Normally, as you scroll through the sagittal slices, the meniscus should look like two separate triangles, anterior and posterior horns, connected by a thin body segment for maybe one or two slices of the bow tie appearance.
Right.
In a discoid meniscus, because it's so wide, that bow tie shape persists across 3 or more consecutive sagittal images, assuming standard 3-do 4 millimeter slice thickness. If you keep seeing that solid band of meniscus connecting the horns slice after slice after slice, it's discoid. Figure 5.3 shows this continuity.
And just seeing a discoid shape doesn't automatically mean surgery, right?
Not at all. Many are completely asymptomatic.
Right.
We only intervene if it's clearly symptomatic, causing mechanical symptoms, or if there's a significant tear within the discoid tissue itself. We see a lot in kids. The challenge is deciding if it's just a finding or the cause of their pain. Sometimes we end up reshaping it arthroscopically if it's unstable and torn.
Okay, the other pseudotear trap, the transverse meniscal ligament, PML.
Right. This is a normal ligamentous band that runs between the anterior horns of the medial and lateral meniscia. It's present in roughly half the population.
And how does it mimic a tear?
The issue is where the TML inserts onto the front edge of the anterior horn of the lateral meniscus. On sagittal images, right at that junction, you can sometimes see a little line or cleft of intermediate or even high signal that looks very much like a small radial tear of the lateral meniscus anterior horn. Figure 5.31 shows this interface.
So how do you avoid calling it a tear?
You have to be systematic. Follow that signal onto adjacent slices and onto the axial images. You'll see it's actually the TML coursing across the front of the joint, inserting normally. Knowing this normal variant exists prevents you from overcalling a tear at that specific location. Hashtag 3.4 tendons and cartilage details.
Okay, quickly touching on tendons. The extensor mechanism quad tendon, patellar tendon, should just be uniformly dark, low signal, right? Best seen on sagittal views, figure 5.32.
Exactly. Thick, dark bands. You look for any high signal within them, tendinosis or frank discontinuity, tear, and you can check the patellar retinacula, the stabilizing wings on either side of the patella, on the axial views, figure 5.33. Tears there can contribute to instability.
And the pes and serenus, those tendons medially.
Yep, the gooth foot. That's the combined insertion of three tendons, sartorius, gracilis, and semitendinosus, onto the anteromedial aspect of the proximal tibia, figure 5.34. Normally just three dark cords running down there. But pes anserinus bursitis, inflammation of the bursa underneath them, is a common cause of medial knee pain, especially in older adults or runners. MRI will show fluid signal in that bursa surrounding the tendons.
Got it. Now, articular cartilage, we know it lines the ends of the bones, thickest behind the patella, right?
Correct. Up to 5-7 millimeter thick there, thinner over the femoral condyles and tibial plateau, maybe 2 to 4 millimeter.
And MRI is great for evaluating cartilage damage, but it's subtle sometimes. You mentioned grayscale stratification earlier, visible on certain sequences like fat-suppressed proton density or T2, figure 5.35. What is that exactly?
It refers to the fact that normal, healthy articular cartilage isn't uniformly gray on MRI. It often shows subtle layers or stratification of signal intensity. The very deep layer, right next to the bone, contains highly organized collagen fibers running perpendicular to the surface, tightly restricting water molecules. This deep zone often appears slightly darker, more hypointense.
Okay.
The middle and superficial zones have more randomly oriented collagen and a higher water content with less restricted water movement. These zones tend to appear slightly brighter, more intermediate to high signal intensity.
So you get this subtle layering, brighter superinitially, darker deeply.
Exactly. That normal stratification pattern is a sign of healthy cartilage architecture.
And when cartilage starts to degenerate, like in early osteoarthritis.
One of the earliest signs is the loss of that stratification. The collagen network starts to break down, water content increases throughout the layers, and that deep zone loses its hypointensity. So it's look more uniformly gray or even bright. You also look for surface irregularities, fissuring, cracks, thinning, and eventually full thickness loss down to the subchondral bone. MRI allows us to grade the severity of cartilage damage using systems like the outer bridge classification based on the depth of the defect. Hashtag 3.5 MRI and arthroplasty, the MARS protocol. Now, for years, getting an MRI after knee replacement was basically useless. The metal implants created such massive artifacts.
Huge black holes, signal loss, crazy distortion. You couldn't see anything near the components.
Made it impossible to evaluate for common problems like infection, loosening, or wear. But that has changed dramatically with the development of specific MRI sequences designed to handle metal.
The MARS protocols again, like we talked about with CT, but for MRI. Yeah.
Exactly. Stands for Metallic Artifact Reduction Sequences. Different vendors have different acronyms: AVARIC, CMAC, VIA-T, WARP. But the principle is similar. They use clever tricks to minimize the signal loss and geometric distortion caused by the metal.
What kind of tricks?
Well, instead of using gradient echo sequences, which are extremely sensitive to metal, they rely heavily on fast spin echo, FSE. or turbospin echo, TSC sequences, which are inherently more resistant to artifact.
Okay.
They also often use higher bandwidths during signal reception, which reduces the spatial misregistration caused by the metal. And some techniques like MA-VARX and CMAC involve acquiring multiple images around the metal with slightly different magnetic field variations, and then using sophisticated computer algorithms to combine them and correct for the distortions.
It sounds complicated, but the result is usable images around metal.
Usable and often incredibly informative. The clinical impact has been huge. We can now use MRI to clearly evaluate for complications around knee replacements that we previously struggled to diagnose.
Like what specifically?
We can see paraprosthetic fluid collections much better, which might indicate infection or loosening. We can evaluate the soft tissues for synovitis inflammation of the joint lining, often caused by wear debris from the polyethylene liner. This shows up as thickened, enhancing synovial tissue.
And osteolysis, bone loss.
Yes, we can often see the extent of osteolysis areas where bone has been resorbed due to the inflammatory reaction to wear particles much more clearly than on X-ray, and sometimes even better than CT, especially seeing the soft tissue component driving it. Figures 5.36 and 5.37 show examples of synovitis and osteolysis seen with these advanced sequences.
Can it show actual loosening of the components?
It can suggest it. We look for fluid signal or abnormal enhancing tissue right at the interface between the implant and the bone cement or the bone itself. If there's fluid completely surrounding a component stem, that's highly suspicious for loosening. Figure 5.38. MRI lets us see that biological response to the hardware, which CT often can't resolve. It's really changed how we work up painful or failing joint replacements.
Okay, moving on to a couple of other tools in the box. Ultrasound. Quick, no radiation. But the big drawback seems to be that it's very operator dependent, right? You need a skilled tech and radiologist.
That's definitely true. The quality of the exam relies heavily on the person performing it, but where it excels, it's fantastic. It's dynamic, real-time, and completely safe.
Where is it most useful around the knee?
It's excellent for evaluating the popliteal fossa, the space behind a knee. Great for diagnosing popliteal cysts, commonly called Baker cysts. Ultrasound can confirm it's a simple fluid-filled cyst and not a solid mass, and importantly, it can use Doppler to rule out vascular things like popliteal artery aneurysms or deep vein thrombosis, DVT, presenting as posterior knee pain. Figure 5.39 shows a typical Baker cyst.
And the dynamic aspect.
That's a huge advantage. You can have the patient actively move their knee while scanning. You can watch the tendons glide, check for snapping, or see if fluid collections change shape. Great for looking at the patellar tendon, especially for tears or tendinosis, or assessing superficial structures like bursae or small fluid collections near the joint line, like perimeniscal cysts. You can also use it to guide aspirations or injections accurately.
And interpretation is based on echogenicity.
Right, how much sound bounces back. Dense things like calcifications or bone surfaces are bright hyperechoic. Simple fluid, like an assist, lets sound pass through easily and appears dark anechoic or hypoechoic. Muscle and tendons have characteristic fibrillar patterns. #4.2 nuclear medicine, physiological mapping.
Okay, last category, nuclear medicine. This feels like a complete shift in thinking. We're not looking at anatomy anymore, are we?
Not primarily, no. Nuclear medicine is all about physiology. We're capturing biological processes, blood flow, metabolic activity, cellular uptake, things that tell us what the tissues are doing rather than just what they look like.
How does it work? We inject something radioactive.
Essentially, yes. We administer a radiopharmaceutical that's composed of two parts, a tracer molecule that is targeted to a specific physiological process or tissue type, and a radioactive isotope attached to it.
Like technetium-99 meter.
Technetium-99 meter, TC-99 meter, is the most common isotope used. It emits gamma rays as it decays. The tracer carries the TC-99 meter to the area of interest, and then a special gamma camera detects the emitted radiation, creating an image map of where that physiological process is happening.
The workhorse scan here seems to be the TC-99 meter MDP bone scan. What's MDP?
Methylene diphosphonate. It's a molecule that gets incorporated into bone, particularly in areas where bone is actively turning over or remodeling.
So it goes to where bone is being formed or repaired.
Exactly. Areas with increased blood flow and increased osteoblastic activity like fractures, infections, tumors, arthritis, even just active growth plates will show increased uptake of the TC-99 meter MDP tracer. These areas appear as hotspots or areas of increased activity on the scan. Figure 5.4.
And we often do a 3-phase bone scan. Flow, pool, delayed.
Right. The first phase, the flow study, is rapid imaging right as the tracer is injected, showing arterial blood flow to the limb. The second phase, the blood pool, is imaged a few minutes later, showing tracer accumulation in the soft tissues due to capillary permeability. The third phase, the delayed images, are taken 2 by 4 hours later after the tracer has cleared from the soft tissues and accumulated in the bone itself. This pattern of uptake across the 3 phases helps differentiate different pathologies. For example, cellulitis might be hot on flow and pool, but normal on delayed, while osteomyelitis would be hot on all 3 phases.
And what about around metal implants? How do they look?
Large metal implants typically show up as photopenic defects, cold spots, areas of decreased activity. That's because the dense metal itself blocks the gamma rays coming from the bone behind it from reaching the camera.
Okay, now the really critical and sometimes confusing application, using nuclear medicine to work up suspected infection, especially around a joint replacement. This often involves 2 different scans.
Yes, this is where it gets sophisticated, but it's incredibly useful. The challenge is that a standard bone scan is often hot around a joint replacement for up to a year or even longer, just due to the normal bone remodeling in response to the implant. So a hot bone scan doesn't necessarily mean infection.
So we need something more specific for infection. The indium 111 labeled white blood cell WBC scan.
Correct. For this scan, we actually draw the patient's blood, separate out their white blood cells, label them with radioactive indium 111, and then re-inject them. These labeled white cells will then naturally migrate to areas of infection or acute inflammation anywhere in the body.
Sounds perfect for finding infection. What's the catch?
The catch is that white blood cells also normally accumulate in active bone marrow. And after a joint replacement is put in, the bone marrow nearby often becomes hyperplastic, more active as part of the normal healing and remodeling response.
Ah, so a positive WBC scan around an implant could be infection, or it could just be normal active marrow fooling us.
Exactly. The N111 WBC scan alone lacks specificity in the post-arthroplasty setting. It tells you white cells are there, but not why they're there.
So how do we solve this dilemma? That's where the second scan comes in, the TC99-meter sulfur colloid SC scan.
Precisely. Sulfur colloid is a particle that is taken up by the reticuloendothelial system. In the context of the skeleton, that means it localizes only to functioning bone marrow. It does not go to areas of infection.
Okay, so WBC scan goes to infection A and D marrow, SC scan goes only to marrow.
Correct. So the strategy is to perform both scans, usually on consecutive days, and then compare the distribution of activity. This comparison gives us the congruent and congruence logic.
All right, walk us through the scenarios. Scenario 1, the WBC scan is positive, hot around the implant. We then do the SC scan, and it's also positive in the exact same location and distribution. What does that mean?
That means the distribution of white blood cells perfectly matches the distribution of normal functioning marrow. The findings are congruous. The conclusion is that the WBC uptake is just due to those cells residing in the normal, albeit maybe hyperactive, marrow space. Infection is considered unlikely. It's essentially a false positive for infection on the WBC scan because the signal is just marrow activity.
Okay, congruous finding, likely just marrow, no infection. Now, scenario 2. WBC scan is positive around the implant. We do the SC scan, and it shows absent or significantly reduced activity in that same area where the WBC scan was hot.
This is the pattern that screams infection. The findings are incongruous. You have high white blood cell accumulation, positive WBC scan, but little or no functioning marrow activity, negative or cold SC scan, in the same spot.
Why is that significant?
It means the white blood cells have gone to that area because there's an infection drawing them there, not because they're just hanging out in the normal marrow space, which isn't active there according to the SC scan. This incongruence is highly specific for infection. Figure 5.41 shows this classic mismatch. Beautifully hot on WBC, cold on SC means infection.
Wow. That dual scanning logic really boosts the diagnostic accuracy, doesn't it?
Immensely. It takes the specificity for infection around an implant from maybe 60% with WBC scan alone up to 90–95% or even higher when you add the SC scan and look for incongruence. It's a very powerful technique for a difficult clinical problem.
That really highlights how these functional scans provide information you just can't get from anatomy alone.
Absolutely.
Just a quick final point on nuclear medicine safety, still ionizing radiation, right? But maybe different levels depending on the isotope.
Yes. We always consider the radiation dose. TC99 meter, used for bone scans and SE scans, has a very short physical half-life, about 6 hours. So the radiation exposure to the patient is relatively low and clears quickly. Indium 111, used for the WBC scan, has a longer half-life, almost 3 days. So the radiation dose from an indium scan is significantly higher than from a technetium scan, although still generally considered safe and well within acceptable limits for the diagnostic benefit it provides. But it's another factor to weigh, especially if repeat scans might be needed. Hashtag tag outro.
Wow. Okay, we started out saying the knee is like a complex machine, and we've really just gone through the entire diagnostic toolbox, haven't we? From that basic shadow puppet show of the X-ray,
Yeah.
all the way to mapping atomic movement with MRI and tracking physiological processes with nuclear medicine. It's quite an arsenal.
It really is. And the key is knowing how they fit together. Remember that triangulation idea?
Yeah.
X-ray gives you the basic chassis, the overall alignment, the obvious bone problems.
CT gives you the precise frame measurements, that detailed bony architecture, crucial for mapping out complex fractures before surgery. MRI gives you all the internal workings, the ligaments, the minutiae, the cartilage, the hydraulics, if you will, the critical soft tissue map.
And nuclear medicine.
Nuclear medicine tells you where the machine is running hot, where there's active metabolism, inflammation, infection, or repair happening, the physiological map.
So for you, the learner, listening to this, I think the big takeaway is that understanding the specifics really matters. Knowing why you order a Rosenberg view instead of just a standard AP for subtle arthritis.
Right.
Insisting on that standing film. Knowing what the Insall cell body ratio tells you about patellar height, or recognizing that a sulcus angle over 144 degrees might mean you need a bony procedure, not just soft tissue work.
Exactly.
It's those details, those specific views and metrics that let you move beyond just looking at a picture and start truly understanding the pathology and, more importantly, the surgical implications. Absolutely. And, this incredible level of detail we can now achieve, it's both a blessing and, in some ways, a bit of a burden.
How so?
Well, we now have tools, high-res MRI, super sensitive nuclear medicine scans that can detect incredibly subtle things. Tiny areas of bone marrow edema, minute stress reactions, maybe microscopic cartilage fibrillation, or tiny meniscal tears that might be completely asymptomatic.
The things the body might have just healed on its own without us ever knowing.
Precisely. Given the body's amazing ability to heal and adapt, how often are we now imaging things that are essentially subclinical? Incidental lomas of the knee, if you will, findings that might represent normal physiological stress or minor injuries that would have resolved spontaneously.
And the concern is?
The concern is, how does the sheer power of these advanced imaging tools influence our decision-making? Does seeing every tiny abnormality push us, perhaps subconsciously, towards more intervention, more surgery, more treatment, when maybe watchful waiting or conservative management would have been the better long-term path for that particular patient?
That's a really profound question. Where do we draw the line between significant pathology that needs fixing and just physiological noise that the body can handle?
It's a challenge every single one of us faces in clinic every day, especially as our imaging gets better and better. Defining that line requires not just technical skill in reading the images, but real clinical wisdom and judgment. Something for all of us to keep mulling over.
Definitely food for thought. Well, thank you for guiding us through this incredibly detailed deep dive into decoding the knee. It's been fantastic.